This video continues Chapter 13 of OEC 6, looking at respiratory emergencies, and will focus in this video on the management of respiratory emergencies. The treatment of a respiratory emergency centers on improving the patient's overall oxygenation. Any respiratory emergency typically leads to hypoxia in the patient, low oxygen levels, or poor perfusion to distal tissues, and so treatment will begin with the possible life threat of ensuring that the airway is open and clear, and along with that, assessing and monitoring the pulse to treat for shock if found. Now, if an airway obstruction is there, if the patient is choking, you must intervene quickly. To clear the airway of a patient who is choking, follow the American Heart Association or American Red Cross guidelines for performing abdominal thrusts. If the patient is responsive and there's no indication of head or spine injury, then we can move the patient to a position of comfort that maximizes respiratory function. This may be the tripod position that allows them to use the accessory muscles to assist the diaphragm with respiration. Do not place the patient in the supine position. This may compromise their efforts. If they have trouble breathing and no shock, we can load them into the patient head uphill and administer supplemental oxygen. Someone in obvious respiratory distress will be placed on oxygen with a non-rebreather mask at 15 liters per minute. High flow oxygen through a properly fitting non-rebreather mask can dramatically improve perfusion. Very mild shortness of breath may be treated with a nasal cannula set at 2 to 6 liters per minute. Most of the time, high flow oxygen by the non-rebreather mask at 15 liters per minute. In the aid room, we can check oxygen saturation level using a pulse oximeter to ensure that it's 94% or greater. If the patient refuses a face mask, such as a pediatric patient, we can hold the face mask as close to the face as possible using a blow-by technique and enrich the oxygen atmosphere just close to their nose or mouth. Also, we may use a nasal cannula at its highest setting, 6 liters per minute. For a patient who requires an inhaler, such as an asthmatic patient, understand that the inhaler consists of the medication in a pressurized canister, the mouthpiece, and a spacer. This will ensure improved breathing by responding to the bronchoconstriction that may be occurring for an asthmatic. If your protocol allows it, you may assist patients having an asthmatic attack to use their own inhaler. They should never use someone else's inhaler and ensure that the inhaler's expiration date has not passed.